Um, so hello, everybody. I'm Corina Mommaerts. I'm an assistant professor in the economics department. I'm, I guess, technically a public economist. I'm in the public economics group, and I study issues related to insurance and risk, and sometimes, but not always, that falls into health insurance and health risks. I study a lot of long-term care, and I think that's kind of how I got into this project about Alzheimer's, as they use a lot of long-term care. But I do other work related to more informal insurance as well as it relates to long-term care and other types of risks. So I think that's me. How did this project get started? I got a call from Jim Paterba, who said that Amitabh Chandra was organizing something about the economics of Alzheimer's disease earlier, pre-pandemic, and they were going to just have a conference about, doing what we're kind of doing today, to brainstorm about research ideas and what economics can contribute to the study of Alzheimer's disease. And then the pandemic hit, and they decided that a virtual conference would not be great for brainstorming, though we're going to prove them wrong by brainstorming virtually. And so we put together a team with Amitabh Chandra, Courtney Coyle, and myself to think harder and write up a little paper, sort of a review article, sort of a brainstorming about what economics can say about Alzheimer's disease. And so here we are. We would love any comments you have on the paper or the presentation for today. If you think we missed something, we are all ears. I'd say neither, so we all kind of come from slightly different backgrounds. None of us are, medical people, and so hopefully we've gotten the basic science right, but if others are more experts, please let us know if we've missed something. And also, what we study, there is some overlap, and maybe we're missing some big piece of economics that can add to Alzheimer's. So Amitabh Chandra, he studies a lot about medical innovations, and so you can guess that the medical innovation part of this paper was written by him. I study a lot of long-term care, informal care, and some healthcare stuff, so I wrote those sections. And then Courtney Coyle wrote the sections related to health more generally, and kind of the savings and financial decision-making aspect of the paper. But maybe we're missing something. So I'm all ears. And as I go along, I was hoping that you guys will chime in, sprinkle in comments, interrupt whenever you want. I'll try to keep my eye on the chat, but I might not be able to. So I'm very open to just, audio interruptions as well. So Jason, is this a good time to get started? Okay. All right. Let's see if I can not have technical difficulties this time. Okay. Can everybody see my screen moving?
Yes.
It's moving. Okay. Okay, great. Let me just pull up the chat so that maybe I can see it. Okay. All right, so as I mentioned, this is a project with Amitabh Chandra and Courtney Coyle. So my plan today was and just kind of as the paper goes through, my plan for today is to do a quick primer on what Alzheimer's disease is, the basic science of it, or at least what we know about it. So that includes the theories we have about the root causes for it, risk factors, and how we diagnose it, which is constantly kind of changing. And economics can contribute a little bit, especially in kind of this risk factor idea as well. Then I'll move on to healthcare and long-term care for Alzheimer's disease. And what we try to argue that Alzheimer's disease is distinct from kind of other diseases like the economics of cancer or arthritis or something like that, is the idea of cognitive constraints. So, as economists, we think a lot about decision making, what happens when our decision making has these frictions related to cognition. And so we'll think about what that means on the demand side, as well as on the provider, the supply side. I'll talk a little bit about informal care and the long-term care workforce, which is less specific to Alzheimer's disease, but as Alzheimer's disease becomes a much bigger issue, those things I think are going to become more important to think about. Then I wanted to move more to the kind of money side of things. How to think about insurance and financial decision makings, again, when we have these kind of cognitive constraints. And then finally, I've left the kind of current and future therapeutics, like drug development stuff, towards the end. So instead of in the basic science section, I left that for the end. And what economists can contribute there, these are, I guess, called push and pull incentives and follow-on innovation. One of this push incentives is public funding for basic research. We kind of normally think about that in this space as basic scientific research for new molecules or something like that. But part of that push, I think, is a place where economists can come in, and so that's where I think we can maybe brainstorm. And part of the push is the NIH providing a lot more funding to economists to develop new economic science, I guess. Okay. So why should economists study Alzheimer's disease? We make an argument based on kind of four main features. So what makes the economics of Alzheimer's disease different from cancer, arthritis, aging? There are obviously overlaps between all of those things, all of those types of literatures, but they don't all have all four of these pieces. And the main piece, I would say, is this cognitive decline issue. But so why should we study it? One reason is the prevalence. It's the third leading cause of death among the elderly, with an asterisk for potentially the coronavirus now, but behind heart disease and cancer. And while heart disease and cancer death rates are decreasing, Alzheimer's rates are rising. There are a lot of disparities here, so it's much more, Alzheimer's disease is much more common among women, Blacks, Hispanics, lower educated individuals. Some of that is, yes, Jeff.
So, there's this classic competing risk issue. Is Alzheimer's more prevalent among women because they're just more likely to last into their 80s?
Yes, that was my next sentence. So it could be the case that women get it more because we are maybe fortunate enough to live longer. Another competing risk is there are a lot of comorbidities between Alzheimer's and other types of disease, heart disease, things like that, that are more common in Blacks, Hispanics, lower educated individuals. So there's a little bit of that going on, but I think we don't have a really great sense for that, in part because our understanding of the basic science is not 100% there. So, while we do know that women get it more, is it because they live longer, or is it because there's something about our brains that are different than male brains, is not totally clear, I think. This is a colossally expensive disease, so it's more expensive to treat than heart disease and cancer, and much of it so on an aggregate level, it's very expensive, and then it's also very expensive at the individual level because much of it goes uninsured, since because much of these costs are for long-term care needs, and at least in the United States, we don't have great insurance for long-term care. A third reason why we should study this is related to cognitive decline, as I mentioned. How does dementia alter decision-making is a super black box. I find this fascinating, and I have no idea where to start. And this brings up a lot of issues that are very salient to economists, including things like family bargaining, if we need to have somebody help us make these decisions. How do suppliers respond in care delivery when the person that they're caring for can't really advocate for themselves? It brings up issues related to dynamic contracting, because maybe we should be making all of these decisions before we become cognitively constrained. So there are you can think of all types of economists, ranging from, family economists, health economists, kind of contract theory people thinking about these issues. And then the other reason to study Alzheimer's disease is we don't have a cure for Alzheimer's disease. We don't even actually have very good treatments for Alzheimer's disease to kind of combat the symptoms. And so there's a huge push for pharmaceutical innovation. And economists have a lot to say about how do we spur medical innovation? How should we design patent systems and things like that for these innovations? Okay, so what is Alzheimer's disease? It's a progressive neurocognitive disease of the brain that leads to dementia. So dementia is not a disease, but just a more general term for the abnormal loss of cognitive function. Alzheimer's disease is the most common cause, but other causes that you may have heard about are things like Parkinson's disease, Lewy body dementia, vascular disease. And let me pause here to say that, while the paper is called Alzheimer's disease, in some sense, we could have just written this paper that said the economics of dementia. I don't think we necessarily are speaking only to Alzheimer's disease. I think part of the cynical reason for why we called it Alzheimer's disease is there are some funding issues where if you want to get certain funding, you have to call it Alzheimer's disease. But for the kind of innovation issues, some of those are very much related to Alzheimer's disease specifically because of how it's formed in the brain. But many of the issues, you could just substitute the word dementia, I would say. Okay, so there are three phases of Alzheimer's disease. The first, and this is not just for your background, but it's also interesting economically, because you can see that how long of a time span this disease really takes. So there's a preclinical disease, and that lasts around 15 to 20 years prior to symptoms even arising. So biological signs can appear in the brain, but you as an individual will maintain normal cognitive function. And so kind of the scientific start of the disease can occur way decades before some kind of clinical definition of the disease starts. Then there is a second phase called mild cognitive impairment, and that's when you start to see things like memory lapses, inability to problem solve as well, but you're generally still pretty independent in your life. And then the final phase is when you have full-blown Alzheimer's dementia, ranging from mild to severe, where you basically need to rely on caregivers. There's a lot of mood and behavior changes, and the median time from the beginning of this phase to death is around 7 years. So you can see that this is a very long-term disease, and it could, I'm getting ahead of myself, but you can see how it could wreak havoc if we are able, which we are starting to be able to, detect it far early in life, what that's going to mean for things like insurance markets, when you kind of know you have the disease, but it hasn't yet appeared, so you can kind of plan for it. Those are kind of things that economists, I think, are very good at thinking through. Okay, so just a quick primer on the basic science. I hope you guys are interested in this. This was very new to me, and yeah, okay, so there's a traditional theory, which is called the amyloid cascade hypothesis, where we have this protein called the APP, amyloid precursor protein. It's a naturally occurring protein in our brain. The exact function of it is not well understood, but this protein is then broken down into what's called AB peptides. And these peptides aggregate to form plaques. And so the issue is that these plaques might be causing cognitive decline. So this hypothesis is the buildup of these plaques is the root cause of Alzheimer's disease. I'll read your thing in a second, Rebecca. So it ultimately, these plaques ultimately could lead to the accumulation of other harmful things and cause damage to neurons and lead to cognitive decline. The evidence we have for this, which is, I'm kind of vague because we don't have great evidence, but this abnormal plaque creation has been shown in people with early onset Alzheimer's, as well as in autopsies. But the problem with it is that we actually don't have much correlation, evidence of correlation between this amyloid stuff and actual cognitive decline. And when I talk about drugs, the drugs that we have that are supposed to that decrease amyloid in the brain actually don't do much to cognitive function. And so while it's doing something to mitigate these plaques, it's not actually doing much to cognitive function. So some people actually think that amyloid is not the cause of Alzheimer's disease, but actually a response to it. But this was kind of has been the going theory for a while. More recent theories is a prominent more recent theory is based on this tau protein. So this is another protein in the brain, and sometimes it causes clumping that then creates tangles of some sort. And unlike amyloid, these tau tangles, we have evidence that those are actually correlated with cognitive impairment in the brain. We also have evidence that they can self-propagate, so make more of them, and that could perhaps account for the progression of the disease over time. So some people are kind of excited about this new theory. Most scientists actually believe in a combination of these two theories where amyloid develops first and somehow puts the brain at risk for tau accumulation. So those are kind of the prominent theories. There are other theories related to immunosuppressants. So it might be something related to your immune system trying to fight infections. This AB peptide that comes from amyloid kills bacteria. And so amyloid may actually be the reason we have amyloid in the brain might actually be a defense mechanism against various illnesses, with the unfortunate downstream consequence for Alzheimer's disease. So amyloid is good for fighting infections, but then it potentially causes this cognitive decline. Okay, so those are the main kind of biological, brainy root causes that scientists have come up with so far. Let me pause for Rebecca. Is that first stage deterministic? Does anyone have early stage disease that never advances to late disease, no matter how long they live? I'm not sure I understand the question. And even if I did, Rebecca, I'm not sure I would be able to answer it. The first stage, you mean like when they're getting amyloid? I don't think I know the answer either way.
I think she means the preceding slide where you had the 15 to 20 year thing. Is that preclinical disease thing imply for sure that you get to the later stages?
I think the answer to that is no, but I'm not 100% sure on that. People's advancement of the disease definitely varies. So some people kind of advance through the different stages faster than others. I'm not sure but I'm not sure if you have these signs, if it progresses so slowly that you never actually get to stages 2 or 3. I'm not sure. Okay. Other risk factors, genetics are a known contributor, and genes are particularly important for early onset Alzheimer's. So most people who develop Alzheimer's get it way later in life, but of the 5% of cases that arise before age 65, there are particular genes that are very much associated with them. So there's one called the APOE APOE4 gene, and so we have like APOE 1, 2, 3, 4, I think, and APOE4 in particular increases your risk by a lot. If you have one copy, if you have two copies, you have way higher chance of developing, especially early onset Alzheimer's. There are some other mutated genes that increase the chance. Interestingly, if you have Down syndrome, you are at much higher risk. Around 75% of people with Alzheimer's develop it by age 65. There are other associated, I use the word associated, behavioral risk factors. So poor sleep, smoking, lack of exercise, depression, are all associated with higher risk of developing Alzheimer's. Air pollution is another one that has recently been shown by economists. Places with higher air pollution have higher rates of Alzheimer's. And so I think there's a large scope for economists to contribute here on this side in both kind of the genoeconomics sphere. I think Jason could talk more about that type of literature, as well as contributing more causal methods to this risk factor stuff. Jason says lots of measurement questions around AD. The recent gold standard of diagnosis is post-mortem brain tissue.
There were just these questions raised about preclinical and how do you and even these tau and whatever measures. Until recently, I think these were either invasive, very invasive, or just rarely done. Is this question Rebecca and Jeff's point about preclinical and mild cognitive impairments? Where would those measures come from? Why would a 40-year-old be subject to a cognitive task and so on?
Yeah, no, I totally agree, and it kind of is related to the literature on when should we recommend certain types of tests, mammogram screening, things like that. So that puts me to the diagnosing Alzheimer's slide. So it's kind of, as Rebecca and you guys are pinpointing, it's useful to differentiate the biological diagnosis versus a more clinical diagnosis, where a clinical diagnosis relies on a physician's cognitive assessment. So it seems like maybe you are exhibiting some symptoms, and so then they do a more thorough, just cognitive assessment. So that happens once you've started exhibiting symptoms. But because of this very early stage biological signs, there is the potential for a biological diagnosis much earlier, so 15 to 20 years earlier, if we're able to design or come up with biomarkers to indicate the presence of tau or amyloid plaques or things like that. And until recently, it was extremely invasive, so much so that that you could only do it through an autopsy. But now we do have the ability to do PET scans and spinal taps, which again are, as Jason said, somewhat invasive. Very soon, in fact, I think it was either in August or September, after we had mostly written the paper, the New York Times had a story about how a blood test should be coming out in the next year or two, which will be way less invasive to indicate some of this earlier stage biological indicators. And these recent developments mean that we might be able to detect it way, way earlier than standard clinical symptoms would allow us to detect in a more or a less invasive manner. And so thinking through what the optimal screening diagnosis type questions are is, I think would be really, really interesting. Okay, so that was my super quick primer. I guess I can pause here if anybody wants to add or augment anything I said here. Okay, let's get to some of the healthcare and long-term care issues, which I really enjoyed thinking about. So treatment for Alzheimer's disease typically involves drug therapies to manage the disease. We don't have a cure, so there's less going on. So a lot of the issues, especially I think for economists around healthcare, are going to be related to how to manage somebody's progression through the disease. As I've mentioned many times now, the distinction that makes Alzheimer's disease care relatively unique to other types of healthcare are these cognitive constraints. And so, when, if you're thinking, if you put on your straight up economist hat, we generally start from a rational benchmark of how people make decisions and how supply and demand interact to create a market outcome. But the question is, what happens when consumers don't actually have the cognitive capacity to act according to their preferences potentially, and they might become dependent on others to actually enforce their preferences, if possible. So insights from, I think, behavioral economics and sociology could help a lot here. What does cognitive constraint even mean here? What kind of constraint or friction are we supposed to be plugging into a model of decision making when we're thinking about the decisions that people with some kind of dementia are making? Is it something like rational inattention? Is it something like time inconsistent preferences? Are they acting like as if they lived 30 years ago, something like that? And so that's kind of thinking about the demand side, and then given that demand side, how is the supply side going to react to these frictions? Are they somehow going to be taking advantage of the fact that people are not making decisions in a, quote, rational way? Yes, Jeff?
So I feel like in an important, I'm in Chicago, I'm all excited about the rational benchmark, but at the same time, I think the behavioral economists have, and the psychologists have taught us that we're always operating under cognitive constraints. So should we, and your list there also suggests a link to the sort of behavioral economics literature, should we be thinking about dementia as just a difference in sort of the intensity of the cognitive constraints that are already there, or in the nature of the cognitive constraints, or what exactly? To me, this is just a continuum where we're already part of the way down, right? I can't accurately predict how long things are going to take, and I've been doing this a long time, and I blame that on cognitive constraints.
Yeah, I mean, I don't have an answer. I guess you're arguing that we all have cognitive constraints, and Alzheimer's disease, people with Alzheimer's disease are just kind of an extreme form of that. But I don't really know what the answer is to how we should think about their cognitive constraints. I mean, for somebody with Alzheimer's, where they think that they're living 30 years ago and their, mother is still alive or something, how does that impact their decision making?
So I would say that's qualitatively different than just sort of being worse at processing, right? Which I think is also a concomitant of dementia.
Yeah, I guess you're saying that there are multiple dimensions of that kind of take us away from the rational benchmark.
I agree with John's comment in the chat, and which is also Bobby's comment in the chat. Except that I think it's different being a future cognitively able person and being a past cognitively able person. Somehow we act differently with those.
Yeah, I haven't thought that much about the analogy to children or infants.
Well, when I thought about it, it seems to me that there is something that's kind of parallel. Yes, forward-looking, you may have more ability, but at what stage and at what point do we think that an adolescent, can they make all decisions for themselves? So it just seems as though these are related questions, though they're clear differences.
Yeah, I guess one fundamental difference is that with somebody who is going to be cognitively challenged in the future but is not today, there are planning issues. They're forward looking, and so they could potentially plan for the fact that they might have these issues in the future. Whereas, when you're children, you're you haven't, planned in the womb or something. But I think all of these comments kind of get to the fact that it's not obvious. And when we as economists are kind of thinking about, how much should we plan, how much should we save for retirement, what should we buy insurance for this thing that could happen to us in the future, we kind of need to know what our decision process is going to be in the future, and I'm not sure we have a good sense for what that is.
So one thing that might be worth having in mind here a little bit is that it does seem on some of the dimensions of like care access and things that, if you want to call it frictions, it's probably going to systematically point in one direction, that once people have Alzheimer's, they're going to think they want less care than their non-Alzheimer's self would think their future Alzheimer's self is going to want. Whereas a lot of other cognitive stuff, the behavioral people talk about is not one directional like that. And so from that standpoint, it may be useful to tie into like the literature on like behavioral hazard as opposed to moral hazard. Like, it's hard to imagine that there's a model in which being insured leads you to access too much long-term care when you have Alzheimer's. Like, making it easy to access care is probably something that at least our non-Alzheimer's selves would want, with sort of unambiguously. So there may be no moral hazard trade-off for long-term care insurance.
Yes.
Alzheimer's.
Okay. Yeah. That's interesting. Let me skip ahead to this slide, which was thinking about this moral hazard aspect, where as a lot of health economists are very worried about moral hazard concerns from an insurance perspective. Classic demand theory says that when we get health insurance, we overuse care, hopefully lower value care. But there's increasing evidence that when we have cost sharing to kind of mitigate these moral hazard issues, it cuts low value care as well as high value care. So we're kind of doing things wrong in some sense. And so the literature is kind of called this behavioral hazard, as Justin also mentioned. And so, when you add dementia to this, what happens? And maybe Justin is right that it's maybe less of a problem. Moral hazard is probably reduced when you have these cognitive these dementia things. The other thing I wanted to mention, another type of question that I think economists can ask, are related to this long-term nature of the disease and what the intertemporal incentives for Alzheimer's disease prevention and care are. So, this care can span decades if we believe that some, behaviors that we engage in, like sleeping well, good exercise, whatever, matter for Alzheimer's disease. And so various things like diagnostic tests, care, insurers might not want to cover those expenses if the cost savings or the benefits from that type of care only have very downstream effects. So if there are early stage interventions that only have these benefits way later, then maybe private insurers are not going to want to cover that if the savings accrue to Medicare. So there's some literature that kind of thinks about those issues, and it could be very relevant for Alzheimer's disease as well. Oops, I didn't finish this bullet. I have no idea what I was going to say. Okay, so let me switch back to, suppose we think when we have Alzheimer's, we end up being more infant-like, or we can't really, we can't really advocate for ourselves. Who could be the advocates for us? So one type of model is that we could have altruistic agents. Family economics suggests that there's a role for adult children as caretakers and guardians, either for kind of altruistic reasons or maybe even selfish reasons. We could use Alzheimer's disease patients as a test for altruistic motives, potentially. So do altruistic motives appear in children whose parents have Alzheimer's disease who might not even recognize their children, even if you don't have bequests? So kind of an extreme version, we could be testing whether children have altruistic motives. What happens though if we have lower fertility rates to this type of protection against people who can't advocate for themselves? If we live in a world with fewer children, we can't really depend on our children to help us as much. So the second type of protection is the state or the government that can use regulation to either discipline healthcare and long-term care practices and make sure that people who are not being exploited. We set minimum quality standards such as staffing ratios in nursing homes for reasons such as this, I think. And the government can be used to collect data to monitor various trends in outcomes and quality measures that can help monitor the providers of long-term care for people with Alzheimer's disease. And finally, we could maybe depend on things like dynamic contracts. Can we design care contracts that are signed decades in advance? So, for example, there are continuing care communities where you move into a care home where you don't really need any help, but with the expectation that once you get sicker and sicker, you've signed a contract where the home would help you. So we could be thinking about those types of questions as well. Okay, skipping forward. So I talked a little bit about demand side incentives. What about provider side incentives? So,
Question?
Yeah, Jeff.
Can you go back to the previous slide? So I was, I don't know why this hasn't come up before, but I'm old enough to very barely remember the deinstitutionalization of the mentally ill. And, at the time, the sort of pre-existing equilibrium was that if they didn't have people didn't have family, or the family wasn't, didn't feel themselves able to manage it, mentally ill people were handled by the state. And in not just paying for long-term care by private providers, but often by state-provided care. And my sense is that the mass deinstitutionalization that happened in the 70s, I guess, resulted from people feeling sort of a combination of saving money, not a noble aim, I think, in this domain, but also a real feeling that the state had done an exceedingly bad job at this. No one was sort of monitoring the monitors. And so a lot of bad stuff happened in state mental institutions. And that part of the deinstitutionalization was, I think, a feeling like, well, is it really worse for some of these folks for them to be kind of on their own, even homeless, than to be kind of medically tortured by state agents? Is there any economics work on this? This would be a rough go, but has anybody ever tried to think about this kind of in cost benefit terms? Either from the agent's perspective or from the state's or society's perspective?
You mean like the cost and benefits of
putting the state in charge versus not, or versus having state-run facilities versus contract? I mean, we were talking yesterday in the public seminar, right, about contracting out and sort of in that context ignoring differences between state and private providers, but here that could be important.
Yeah, I mean, I'll mention two things. I don't know if they're answers, but one is that it's not just mental institutions, but in fact, these as well were part of that same kind of movement and counter movement where we institutionalized also the elderly who could not care for themselves in nursing homes. And so they weren't always state provided nursing homes, but the state, when they came in because people couldn't afford to get care on their own, the state put them into nursing homes. The counter movement was a Supreme Court case that was, I think, the combination of people with mental disabilities as well as people in nursing homes for frailness and that kind of disability, who said we want to remain in the community. We have a right to be in the community and not institutionalized. And so I think it was a parallel movement. So we're not really talking about separate populations here. And so there is a literature that talks about kind of what happens when you get people out of the institutions, but not really, I think, in the way you're thinking about it. I think, like, if you just continue with the logic of like who's the one that's looking out for you, if the state could look out for you, they have some altruistic motives where they care about you, but like if they don't actually care about you, nobody's monitoring the state, then who is going to? Like it often always comes back to family or nobody. Like there's no answer in the end, it feels like.
Yes, it's a hard problem.
But that's kind of why, like, this third bullet point of like, well, maybe we can rely on some kind of self-enforcing contract, these like magical contracts that.
But again, there has to be somebody around once you've become once you have dementia. There has to be somebody around to enforce that contract on your behalf, right?
Exactly, right. And so like one way you could maybe think of it working is something about overlapping, in econ speak, like overlapping generations, where like for me, yeah, if the end of the world was just when I died, then yeah, the provider is going to renege and give me really bad nursing home care. But they know that they need new patients in the future. And so if we have at least the state that's there to kind of do the monitoring, collecting the data to say like, oh, this nursing home is really terrible quality, then that could be kind of a self-enforcing mechanism. The quality that the providers give to the incapacitated today then feed back into the patients that they're going to get in the future. Something like that. Okay.
I didn't have a solution. I just wanted to raise the parallel to mental health and raise the question of whether economists had worked on that kind of related problem at all. Or other social scientists. I don't want to privilege economists.
Yeah. Bobby says we do have dynamic contracts now. You mean like with these? I
mean like a contract you can go into a place that's for older adults where you're paying a certain amount, and with that you have a guarantee that as you need more care, the care will be provided, including a memory unit.
Right. Yeah. Yeah. So it does seem like they kind of work, but to the extent that they depend on kind of this future generation for, or whether it's because the people in them have other people monitoring the quality of care being provided, like their family members are checking in to make sure things are good, I think is a question.
Right. And there are some instances that reach the courts where someone the institution itself has not met what they signed on for, but that requires monitoring of whether it's friends or relatives, or someone has to be doing the monitoring of the institution.
Yeah, exactly.
Can you hear me now, Corina?
Yeah.
One add-on to what Bobby was just saying is, I think in some of those cases, it could be the future generation of people who would sign with the institution that are kind of doing the monitoring. So having some kind of financial link, like if I'm not sure I understood the situation well, but I thought I'd seen one situation where the building itself would own the condo after someone passed, and in that case they would have the incentive to preserve the reputation of their services and the fact that they would do what they said they would do even in the case of a memory event, because they would be the one monetizing that reputation.
Yeah. Yeah, no, yeah, I totally agree. Yeah, this like future generation seems like it is maybe key here. But yeah, I guess like you'd have to think through though how to get rid of like these one-off type places that only exist once and provide really terrible care and then exit the market. But yeah, anyway, so yeah, these are interesting questions. Provider side incentives. Traditionally, providers have been paid fee for service for a lot of care for people with Alzheimer's disease. End of life, and this is not just relevant for Alzheimer's disease, but for a lot of care, Medicare provided care. So, but I think end of life care for Alzheimer's disease patients could kind of highlight some of the acute issues related to, for example, fee for service issues. So Alzheimer's disease, so one example is Alzheimer's disease patients are much more expensive typically than other nursing home residents. So especially when they have these memory events where they need to be looked after pretty much 24/7. So they are much more expensive, but the nursing homes, especially if these are poor individuals, receive flat per diem rates for these individuals. And so these are not people that are lucrative for nursing homes. And so nursing homes face incentives to do many things, one of which is to maybe not take in people who have Alzheimer's disease. They also, but if they do have a patient that has Alzheimer's disease, there's some evidence that nursing homes play games where they transfer patients to hospitals despite patients not really needing hospitalization, and that triggers an amount of time where they get higher Medicare rates as opposed to Medicaid rates. And this is just kind of a feature of the fact that that these people are very expensive, and these providers, they're in some sense profit maximizing. This is often this is not just a question about money and wasteful money, but it's often associated with questionable medications. Burdensome hospitalization transfers are very bad for people's health towards the end of life, and so this is something that we want to avoid. And so this kind of highlights some of the issues with the structure of our system, where we often pay providers for the services rendered, not the patients themselves. There has been some evidence that structures that are more pay for performance, which incentivizes people or providers to minimize costs as opposed to maximizing payments to them, could result in lower cost care and fewer of these burdensome transfers. There's evidence that coordinated care might be beneficial with, you have kind of a point person that is helping organizing the care for somebody. This is particularly relevant for Alzheimer's disease patients that have interactions with a lot of parts of the healthcare system. They go to hospitals, they go to doctors, they go to long-term care facilities, they get home care, and they might be going back and forth between these places. And so coordination might be a very interesting topic for thinking about Alzheimer's disease care. The kind of issue with these more pay for performance type structures that might be more willing to do these experimental things like coordinated care is that they often have the incentive to reduce quality. And this could be particularly concerning for Alzheimer's disease patients if they're not, again, effective self-advocates. They don't know how to advocate for themselves properly. So, as there are a lot of transitions to away from fee-for-service and toward capitated payment plans, we might be worried about that transition for Alzheimer's disease patients. There are a lot of kind of pilot programs around the US that are doing things specifically for Alzheimer's that could be useful for economists to study. Okay, so let me talk a little bit about long-term care. This, maybe I can breeze through this quickly because it's not necessarily particular to Alzheimer's disease, but much of long-term care for Alzheimer's disease is informal. So around a third of people live in residential care facilities, such as nursing homes, but not only nursing homes. But most people receive the care in the community, and the majority of this care is actually informal. And so some of the open questions here are, it's relatively straightforward to calculate costs of formal care. We kind of know what well, maybe we know kind of what the price for certain formal care services are, but it's really hard to think through what the cost to informal care is. So I have some work in this area, but it might be interesting to think about this for Alzheimer's disease patients in particular. How do families make decisions between receiving formal versus informal care? How has the introduction of assisted living facilities, special memory care units that have been shown to be somewhat effective, how do those newer crop of facilities affect the decisions that people are making, and also kind of the risk selection of patients? So, if all of the people with Alzheimer's disease are going into nursing homes, but everybody else that doesn't need as much care is being channeled into assisted living facilities that are kind of more pleasant and cheaper, what does that have? What's the effect of that on these nursing homes that rely kind of on a per diem Medicaid reimbursement rate that it could cause trouble if there are kind of selection into and out of these different facilities. One question that I don't think we have great answers at all is, are there differences in health outcomes between various care modes? So for people who decide to go into nursing homes versus to stay in the community and get care from a family member, what is best in terms of their health outcomes, I think, is an open question. Okay, one little plug about the long-term care workforce, this is also not specific to Alzheimer's disease, is long-term care is extremely labor intensive. This is not really something that you can substitute capital or something for instead of labor, and so that's part of why long-term care is extremely expensive. You just need somebody to be watching you and helping you. It's often provided by a direct care workforce that's very low paid and often depends on immigrant workers. We currently have a shortage of direct care workers, and it's projected to grow a lot over time, particularly if immigration policies change, things like that. This shortage is associated with lower quality. This lower quality is kind of correlated with low pay as well. The tightness of the labor market affects supply. And so, so if it's a very tight labor market, fewer people want to be in the long-term care workforce. They want to be doing something else. But, these kind of shorter term fluctuations kind of wreak havoc on the payment system to places like nursing homes because of these rigid Medicaid reimbursement rates again. And so, thinking through these fluctuations seems important. What policies can we leverage to increase this workforce? There are ideas related to immigration policy, of course, minimum wage policy, regulations in terms of how nursing homes need to staff people. Other things to think about are things like technological advancements. So, maybe robots can play a role here. That's not really a joke. That I know, like Japan is kind of at the forefront of testing robot technology in places like nursing homes. There are researchers studying the use of GPS tracking software to know if somebody has fallen or something like that, which maybe would reduce the need for as much monitoring labor. So I think there's a lot of opportunity there to think about the long-term care workforce. Okay, so another topic, insurance against the risk of needing Alzheimer's care. This is kind of about long-term care risk more generally. It's not so much about medical care risk. We have better insurance against medical risk in the US than long-term care risk. And my brief summary is that this is just a disaster. So Medicare does not cover most long-term care costs. Alzheimer's disease patients are often in the right tail of these long-term care costs. They need a lot more than kind of your typical long-term care patient. Medicaid does cover long-term care costs, but you have to be impoverished. Private insurance does exist, but it's a very, it's a market that's in a lot of trouble. It's struggling, it's dying. I have some work in this area. Naoki is also working in private long-term care insurance. Some of the issues that pop up about why this market doesn't exist, just a couple of reasons. There are a lot, but one is about aggregate risk. When you sign, this is a dynamic contract again, where you sign when you're in your 60s, and you might not need care until you're in your 90s. Insurance companies have to guess what the world is going to look like when you 30 years down the road. And if we've found a cure for Alzheimer's, the world looks very different, and the costs to them are very different than if we don't. And so that's a very hard product for them to provide. And there's also private information concerns. So we maybe have a good sense from our family history or something about whether we're going to develop needs for long-term care, such as Alzheimer's disease. And so some of the open questions here, I think, are how will advancements in genetic testing and diagnostic technology for Alzheimer's disease affect the adverse selection problems in the private long-term care insurance market? It seems like it could be like a really big deal. There's some interesting work by Emily Oster on Huntington's disease, which is another kind of neurological disease that generates a lot of long-term care needs. She shows a lot of adverse selection due to that. But Huntington's disease, of course, is a very rare disease. Alzheimer's disease is a very common disease, and so it could cause a lot of problems in this market. Another question is, should insurers be allowed to price on it? We have some regulation for genetic information. There's kind of an oldish law called GINA, Genetic Information Non-Disclosure Act, something like that. That means that we can't price genetic information into health insurance, but it is pretty silent on long-term care insurance. And so there are a lot of interesting questions there. There are questions related to, should insurance cover informal care? That's some work that I've been really interested in. Does the coverage of informal care introduce moral hazard? And then finally, a very hard question is, do individuals actually want insurance when they're suffering from Alzheimer's disease? So, some people think, if I develop Alzheimer's disease, I'm just like a different person. I don't really want to, I don't really want to transfer resources to that stage of my life if that's what happens to me. And so, maybe people don't actually even want insurance for that state. This is kind of the state-dependent utility literature that is a really tough one.
Corina,
Corina,
can I say one thing? So I'm from Japan, so and I think Japan, the cognition issue is a very important issue because we are a very aging country. So in Japan, actually, there is a specific insurance against this cognitive issue. So this is primarily for the AD, in my understanding, and this is sold by life insurance company, and then this seems to be quite popular. So I don't really hear that this market is really dying or struggling, but this is one observation that maybe there may be some lesson we can learn from Japan about the operation of this AD type of long-term insurance market.
Yeah, I had no idea. So how are they dealing with kind of genetic information issues? Do you know?
I don't know yet.
Or is this something where like everybody has the insurance? Is it social insurance?
No, this is just sold by private companies, and then it seems that people are really buying it. But also, like a public insurance also cover like a certain part of like informal care, so that maybe there may be some complementarity between the the public and private. That's why maybe private companies think this is not so costly. But I don't know. But I think that the point is that there are, one observation is that there may be more bigger market in Japan for AD type of insurance.
Yeah, that's interesting that they have like a specific insurance for cognitive.
Yeah, they have a specific insurance to the cognitive, just for the cognitive issues.
Yeah, that's really interesting.
Yeah.
Thanks. Okay, financial decision making. So remember, Alzheimer's disease risk is not just medical risk, but also this cognitive risk. And so we could think through whether the risk of developing Alzheimer's disease affects your earlier life financial decisions. So how much to save, if you think that there's a risk of needing needing care for Alzheimer's disease, how much to work, how much do you want to spend down assets in retirement, how much do you want to annuitize? These are kind of classic literatures in kind of labor public economics, and thinking about the twist with Alzheimer's disease could be interesting. How does actually having, not just the risk, but actually having Alzheimer's disease affect your financial decision making? We could think about financial literacy concerns. There's parallels with that kind of literature. Financial mistakes. So do people with Alzheimer's disease are they more likely to pick the wrong Medicare Part D plan? Portfolio choice, are they making really bad decisions or good decisions maybe about what to invest in? Their susceptibility to fraud is a definite concern. And so these are kind of broad issues. And so we might want to think, how should we design policies to protect individuals who have cognitive decline from things like financial mistakes or exploitation? Some ideas have been floated around, such as financial driver's licenses, stronger fiduciary requirements by banks and stockbroker type people. You could think about other legal modes where we once we develop dementia, we hand over our, here we go again with the who's going to look out for us, but we hand over our financial responsibilities to somebody else, such as Social Security's representative payee program. Something like 6% of people with Alzheimer's disease are in that program, where they've designated somebody else to handle their finances. Jeff and Rebecca. Jeff, do you have a comment?
Yeah, so I remember hearing about some work when I was at Michigan using HRS that looked at married couples, and they keep track in the HRS of who does the household finances. And they also give people cognitive tests every round, and they also ask you about your general disability status. And my sense was that there was sort of evidence on, how much cognitive decline one partner has to experience before they hand off the financial duties to the other partner.
Oh, interesting. That might be work by Joanne Sue?
That could actually, that sounds very plausible now that you say it. I was on her committee. But
I didn't realize the connection there with Alzheimer's disease or dementia, but yeah, her work is on.
It may have just been the decline in the cognitive test without specific reference to dementia. I don't remember, but that would be interesting information if you were trying to calibrate some sort of broader standard. When do couples think it's time to hand those duties off, right?
Yeah.
In a sort of observed way.
Yeah. I thought hers was like, when do they think they're going to die? And so then at that point they need to
No, I'm pretty sure there was that may be a different paper. I'm pretty sure there was a paper about cognitive decline and switching the household finances.
Okay. Thanks. Okay. Rebecca says, one financial risk that could occur is not paying one's bills, including long-term care insurance. Yes, very much so. So people might not pay their long-term care insurance premiums. So there's like a correlation between the risk of developing dementia and then like losing your long-term care insurance. That seems very real, especially because in long-term care insurance, there's a very high rate of lapsation where people stop paying their their premiums. And so, there are papers that think about whether that's like a rational response. They stop paying because they develop new information about their risk of needing long-term care, or is it something that's more like a mistake? Yeah. That I don't think we explicitly say that in the paper, but that's interesting. Okay. So now I wanted to transition the last few minutes about drug development. This is not something I knew very much about, but I think it's really interesting to think about. So we are unfortunately very far away from a cure. So scientists don't think we're going to develop a cure anytime soon. Just to give you a sense of where we are, there are currently 4 FDA-approved treatments to help with cognition, to help with Alzheimer's disease. They don't really work very well. They have a very small effect on cognition and virtually no effect on the progression of the disease. In terms of like the volume of research and development going on, there's actually quite a lot. So pharmaceutical companies, biotechnology companies, and academic centers have brought 413 drugs for Alzheimer's disease to trial in a 10-year span. I guess that was 10 years ago. And basically, they all fail. So the failure rate was 99%, and none have been approved since 2003. There are much higher costs to drug development for Alzheimer's disease than many other drugs. The average length of developing the drug is around 13 years, in part because of the long-term nature of the illness. So what that means is, and this will come up when we talk about patents or exclusivity rights, but what that means is, to test the effectiveness of these drugs, you have to wait long enough to see if they actually worked. And so if it's a drug that says we're going to lower the rate of progression of the disease, you might have to wait 10 years after you've given a patient that drug to see if it actually worked. And so that costs a lot of money to have to wait that long in terms of both just R&D costs, but then also patent exclusivity rights. Okay. So just a quick primer on the types of therapeutics that are kind of ongoing. The main one is drugs that try to just help with your symptoms, that try to reduce suffering. And so all the drugs that we have are in this category. A quarter of those in the pipeline are in this category, whereas the rest are like trying to actually fix the disease. Most of these symptomatic drugs are trying to enhance cognitive capacity or alleviate psychiatric or behavioral symptoms that often occur in these patients. And as I mentioned in the last slide, they don't work that well. Bobby says the high cost seems tied to our lack of understanding about the biology. Yeah, I would think that once we have more of the basic science, the cost of drug development to some extent will go down. Of course, these the length of clinical trials might not decrease, but yeah. The second type of therapeutics that are the main one is disease-modifying drugs. So that's trying to stop the progression. These, if you remember back to the science, they're trying to target this amyloid. That's the most common type of drug, or the tau tangly type things. There are alternative therapeutics that companies are experimenting with that are modulating inflammatory responses, things like gene therapy, regenerative biology. I don't really understand what those things mean, but they're out there, but they're not kind of the main thing. Even weirder ones that are not weirder, but like more experimental ones are blood transfusions from young donors. There's a company in China, or I think China's version of the FDA has just approved something related to some carbohydrate in kelp. But those are kind of more out there. The main ones are thinking about just reducing symptoms and stopping the progression of the disease. And so I think economists have a role to play in thinking about the incentives to come up with these new drugs. And there are kind of three ways to think about it. One is through what are called pull incentives, and then there are also push incentives, and then something called follow-on innovation. So pull incentives are basically just policies that increase the expected profits, which then increase research and development. And so those are things like patents or R&D tax credits. And so I'll get to that in a second. Follow-on innovation, the idea there is that once a drug is patented, then it becomes public in the sense that people can see how you made the drug. And so other firms can kind of invent drugs or develop drugs around that patent, which could be a good thing. And then push incentives are kind of where we'll end, which is the public financing of basic science. So just like throwing money at people to do basic science. So what are pull incentives? This is just the idea of trying to make research and development more profitable. Expected profits depend on market size, prices, manufacturing costs, and obviously the probability of failure. And so policies that can help affect these profits are things like patents, tax credits. One thing that we mentioned earlier about like diagnostic testing is you could imagine pull incentives to increase the market size for these drugs if the government says we should all get diagnostic testing for Alzheimer's disease at age 40, and it turns out that shows that a lot of us are at very high risk of it, and then companies might want to invest in drugs to try to help with the disease, given the fact that the market size just increased a lot because we are now getting diagnosed. The challenge in terms of kind of patent policy more generally, and particularly in Alzheimer's disease, is how to actually design patent policy and exclusivity periods. So how much time should a company be allowed to produce and to exclusively produce their drug without having any competition from others? Is the effective patent length long enough to encourage R&D or no? I say the word effective is because that patent length, my understanding of it, is that it includes the clinical trial within the patent length. And so trials for long-lasting diseases like Alzheimer's disease eat away at that exclusivity value. And so people like Heidi Williams have done a lot of work to show that drugs that are for late-stage cancers are much more profitable, and so companies invest in drugs for late-stage cancer rather than early-stage cancer because it's much quicker to see if a clinical trial worked for late-stage cancer because it's kind of near the end, I guess. And so for Alzheimer's disease, this is a very important issue because Alzheimer's disease is a somewhat slow progressing disease that, and so clinical trials can last a long time. There aren't great pull incentives for discovering non-pharmaceutical ways to prevent Alzheimer's disease, like knowing whether sleep is good for decreasing Alzheimer's disease rates, because it's hard to patent those types of ideas. Apparently, I'm not a patent lawyer. I don't totally understand these things, but apparently it's hard to patent that type of idea, and so that's going to lead to underinvestment in such discoveries. So things related to more like risk factor type things as opposed to pharmaceuticals. And that's where these push type incentives come in. Just a quick word on the follow-on innovation. So as I mentioned, once a drug is patented, it becomes public, and so other firms can invent around it. They know, like, the invention you did, that was the trade-off that you got for having this exclusivity period is now everybody else can see what you actually did. And so that can be a good thing if other firms can invent drugs that are kind of close by. But if you, like, thinking about as a policymaker, if you expand the patent to be like very broad, then other firms can't actually invent around because the scope of your patent is so large, and so that could dampen research and development for these kind of side or follow-on drugs. And so you can kind of see the trade-off between, you want to make a patent generous enough for companies to want to invest in R&D, but you don't want to make it too generous, because then it might hamper kind of discoveries kind of that follow up on those on the patent. Another note is that Alzheimer's disease treatment is likely going to involve multiple drugs for multiple targets, so like some kind of cocktail or something. And so these kind of follow-on drugs or inframarginal medicines might actually be extremely important to think about. So this follow-on innovation issue seems important, and economists have frameworks to kind of think about these types of cost-benefit trade-offs. And this is my last slide, and then I'll stop talking. But push incentives are just ways to kind of fund basic science. And so there are big market failures in basic science. It's hard to patent basic science discoveries, apparently. And so private firms don't often do that. Private firms are more interested in developing the drugs that we're going to actually take. But because we don't actually really understand the basic science, as Bobby says, this type of research is actually very, very important. And so this is potentially why we've seen a lot of increased public funding for Alzheimer's research in recent years. I don't actually know how this compares to other diseases, but we spent $2.2 billion on Alzheimer's research in 2019. So I hope in this talk and in the paper, I've convinced you that there is room for basic economic research as well. There certainly is funding for it, and so yeah, I'd love to discuss more and get to work on some Alzheimer's research.